morning. I am Dr. Sharad Jain, Professor UNMICRC Institute. Today I am going to speak regarding ambulatory blood pressure monitoring, which is a very important parameter for the diagnosis of hypertension in today's clinical practice. So, if you see India soon heading towards a epidemic of hypertension, at least 1 out of every 5 adult Indians has hypertension. Hypertension is responsible for around 55% of stroke deaths and around 25% of CHD deaths in India. So, it is very important. Accurate blood pressure measurement is an important as treatment in hypertension management, because the treatment depends upon the accurate blood pressure measurement. Suppose if you overreach by 5 millimeter of mercury, then there are 18% hypertensive patient overdiagnosed. If you underreach by 5 millimeter, then there are 3% patients which are missed. So, accurate blood pressure measurement is very important. So, high BP is not a definition, it is a triad as opposed to the specific disease, and represents a quantitative rather than a qualitative derivation from the norm. Any definition of hypertension is therefore arbitrary. In the practical definition of hypertension, the level of blood pressure at which the benefits of treatment are more as compared to the hazards. So, the very important person, the Kaplan, he is considered the father of hypertension. He said the measurement of blood pressure is in clinical procedure of greatest importance, but performed in very slopiest manner. It is taken in very casual manner. So, starting from the history of, if you see that there was a Rossi sphygmomanometer, that is a mercury blood pressure, and you can just take systolic blood pressure with that. So, with the invention, newer machines becomes available. So, blood pressure measurement, it can be in the office or in the clinic, that is the most practice, and out of office, that is blood pressure, which is home blood pressure monitoring or ambulatory blood pressure monitoring, which home blood pressure and ambulatory blood pressure provides a large number of blood pressure measurement away from the medical environment. So, office blood pressure measurement has been the cornerstone of hypertension treatment, and still it is cornerstone, because most of the time it is the only way which patient is treated. It is available since last 100 years. Most of the hypertension patients are diagnosed and treated on the basis of office based readings. So, the ideal office blood pressure measurement requires multiple steps, which is many times lacking in today's busy clinical practice. So, AHA guidelines for blood pressure measurement emphasize it should be a trained observer, correct patient position is important, a period of quiet rest before taking blood pressure, use of appropriately sized cuff is very important, minimization of extraneous factors that influence blood pressure, such as patient should not have smoked at least in last 1 hour or taken caffeine, intake that means coffee or tea or steak, intake prior to blood pressure measurement. So, the ideal office blood pressure reading requires to allow the patient to sit for at least 3 to 5 minutes before beginning BP measurement, to take at least 2 BP measurements in the sitting position, which are separated by 1 to 2 minutes apart, then to take repeated measurement if the BP to improve the accuracy to patient with arrhythmia such as atrial fibrillation, to use a standard blood cuff, that blood pressure cuff, that is 12 to 13 centimeter wide and 35 centimeter long, but have a longer and a smaller blood pressure cuff available for larger arm and for the shorter arms respectively. To have the cuff at the heart level whenever the patient of the sitting. When adopting to auscultatory method, use phase 1 and phase 5 corticoff sounds to identify systolic and diastolic blood pressure. To measure blood pressure in both arms, at least for the first visit, you should take blood pressure in both arms, and if required also in the lower limb. The measurement of the first visit BP 1 to 3 minutes after association, and then you take the blood pressure in the standing position when the patient is stand already for 3 minutes, which is very important to diagnose the orthostatic hypotension as well as the in diabetic patient, and especially the elderly people. So, the limitations of the clinical blood pressure are various, like the white coat or masked hypertension, which I will discuss later. Blood pressure is variability, then the dipping abnormalities, early morning surge of the blood pressure, and treatment responders. So, coming first to the white coat hypertension. White coat hypertension is defined as clinic blood pressure of more than 140/90 or higher, at least on 3 occasions, with at least 2 sets of measurement of less than 140/90 in non-clinical setting, that is in the home settings or any other setting, plus the absence of and there is no target organ damage. So, factors which affect the blood pressure measurement result are setting, patient is in the office, it is workplace, whether it is ambulatory or home, then the time it is taken in the daytime, night time, the nocturnal dip, which is the dip in the blood pressure with during sleeping, patient in the morning surge, then the observer, whether patient is person taking blood pressure is a doctor, nurse, technician, or relative or self measurement by automated instrument. The device, which are various devices available, mercury, aneroid, hybrid and oscillometric, and the posture, patient lying down, seated or standing or exercising, reading first day, etc., and the calculation, average variability, reactivity minimum. So, blood pressure variability is very common. The blood pressure varies from time to time. It is just like the share market, which varies from just in 2 minutes, blood pressure can vary from different timings. So, measures of BP variability, stability or reactivity are variability, short term reading, that is in reading to reading in ambulatory blood pressure monitoring, medium term, that is day to day in home monitoring, and long term, that is office measurements. Instability, maximum blood pressure office, home ambulatory monitoring, morning BP surge, etc. And reactivity, that is with the physical test, isometric or after isometric or isotonic exercise testing, cold pressure test, and then the mental test, like even after the arithmetic task, reaction time, etc. So, may carry different clinical implications, which are blood pressure still poorly understood. Even in the HOPE trial, when the clinic blood pressure measurement was compared with ambulatory blood pressure monitoring, it exhibited major differences. That is, if you see that graph, the clinic blood pressure was lower and the 24 ABM has shown higher blood pressure as compared to the clinic reading. So, limitations of clinical blood pressure measurement are device induced mercury based devices. Mercury usage is going to be prohibited because of this toxic mercury reactions. So, it should be slowly it is going to be replaced. Then the digital devices, like accuracy and reliability is concerned. Then the calibration, which is required, many a times we see that calibration is not done for even 5 years, 10 years. So, calibrations at important times is very important at different intervals. Coming to the ambulatory blood pressure monitoring, that is ABPM, monitoring involves measuring blood pressure at regular intervals, usually every 20 to 30 minutes over a 24-hour period, while patient can undergo normal daily activities including sleep. So, ABPM, the use of 24 ABPM was introduced in late 1970s. In the beginning, the devices were large, very heavy and cumbersome, so it was difficult to carry on for the routine work. But today, devices are very lightweight. Nearly all of them use an oscillometric measurement method to compute BP levels. This method eliminates observer bias because it provides automatic blood pressure information. The large number of readings obtained during the patient daily activity provides a natural blood pressure history, and superior assessment of true BP can be done. Additionally, 24-hour ABPM provides information on BP variability, that is circadian changes with the change in and the effect of the environment and emotional conditions on BP levels. So, the indications for ABPM is, if you are suspecting a white coat hypertension, especially even in the pregnancy also, if you are suspecting masked hypertension, that I will discuss you later, untreated subject with normal clinic blood pressure and elevated home readings. Suspected nocturnal hypertension or nighttime reduction in BP, that is dipping, hypertension despite appropriate treatment, and patient with a high risk for future cardiovascular events, even if the is, suppose patient with the diabetes or CKD, even if the clinical blood pressure is normal, suspected episodic hypertension. Then in treating the antihypertensive therapy and titrating the antihypertensive therapy, patient with borderline hypertension, hypertension detected early in the pregnancy, suspected or confirmed sleep apnea patient, syncope or other symptoms suggesting orthostatic hypotension, where this cannot be demonstrated in the clinic. So, if you see the 50 years back, the ABPM instrument was very cumbersome and very heavy, but now in modern practice it is very simple. It's just like a mobile and a cuff which is inflates at regular intervals. The portable monitor is worn on a belt connected to a standard cuff on the upper arm. When complete, the device is connected to a computer that prepares a report of 24 hours, day time, night time and sleep, etc. The instruction given to the patient is to keep their arm steady during measurement. When the BP starts inflating, then you have to keep the arm steady, to keep their arm at a heart level during measurement, to engage in normal activities between the measurements and to keep the monitor attached at night. Provide a diary card to the patient to record their activity level at the time of measurement, the time they go to bed, the time they go up to their time, and during drug treatment, etc. So, ABPM ambulatory blood pressure monitor use cuff oscillometry. The cuff is inflated until the pressure occludes flow within the brachial artery. As the pressure is released, blood begins to flow, causing fluctuations, oscillations in the arterial wall that are detected by the monitor. These oscillations increase in intensity, that diminish and cease when blood is flowing normally. The monitor defines the maximal oscillation as the mean arterial blood pressure, and then systolic and diastolic are calculated from it. So, the advantage of ABPM is that you can have the true or the mean blood pressure, and you can see the diurnal blood pressure rhythms, which are, you can see the dipping status of the person, morning surge, blood pressure variability, duration of drug effects, which cannot be seen in the clinical blood pressure monitoring, and many things are questionable in home blood pressure monitoring. So, coming to the analysis of ABPM, requirement for satisfactory ambulatory BP measurement should be taken every 30 minutes during the day and night. Measurement sometimes taken every 15 minutes. Can interfere is not required because it can interfere with the activity during the day, which is so quick, can interfere with the sleep at night. Daytime, at least you need 14, ideally you should have 20 measurement, but at least 14 measurement to be a successful ABPM of systolic and diastolic blood pressure. Night time, usually 7 measurements is okay, because the night time is also less, because sleeping is usually considered 7 hours. If minimum requirement is not met, then you have to repeat the same. So, the reference normal BP values for non-pregnant adults are 24 hours average, it should be less than 115 by 75 mercury mm of Hg, that is the hypertension threshold is considered 130 by 80. Daytime, that is awake, should be less than 140/80. Hypertension threshold is 135 by 85. Night time asleep, that is it should be less, because of night time usually BP goes down. So, less than 105 by 65, and hypertension threshold for 120 by 75 mm of Hg. So, ABPM diagnostic threshold 24 hours more than 130 by 80, daytime 135 by 85, and night time if it is more than 120 by 75. So, ambulatory blood pressure values above normal and below threshold for hypertension are considered higher normal blood pressure. Night time average systolic and diastolic pressure should both be at least 10% lower than that daytime blood pressure, that is the nocturnal dipping, normal nocturnal dipping. Blood pressure load, the percentage of time that the BP readings exceed hypertension threshold in 24 hours, if it should be less than 20%. Here is a reading, you see that the blood pressure, the normal levels during the day and the night, and while awake, it is all above the normal range of the blood pressure. And Here if you see that the mean blood pressure is also higher with the red numbers, and even the daytime blood pressure is also normal. Or just no, okay. And if you see when the patient goes to sleep early, that is at 10 p.m. and but the dip is only 3.9%, which is less. But if you after sleeping for 2-3 hours, that around 1:30 a.m., then the dipping is more than 14%. So that because patient was able to sleep late, even though he is going in the bed early, but not able to sleep early. So you can see that the blood pressure is above normal. So you can say that it is grade 1 hypertension, but with normal dipping pattern. So advantages of ambulatory blood pressure measurement over office blood pressure measurements are that if you see the prediction of cardiovascular events with that ABPM, if you see a prospective cohort study around 1500 patients which were followed for around more than 6 years, showed that the ambulatory blood pressure was significantly better related to stroke risk than were the screening office blood pressure levels. Similarly, a study of around 1000 patients in 24-hour daytime and nighttime ambulatory blood pressure was closely associated with the risk of silent cerebrovascular lesions detected by brain MRI as compared to the office readings. Of the ambulatory BP values, nighttime BP was the strongest predictor of silent cerebrovascular events. So the identification of white coat hypertension, many studies have shown that the white coat hypertension carries a more benign prognosis than the sustained hypertension. This may be related to the high risk of developing true hypertension in patients with white coat hypertension. So in those with confirmed white coat effect, a 24-hour ABPM follow-up should be done at regular intervals at 6 to 12 months to determine that they are not developing real hypertension. So white coat hypertension may be present in as many as 20% of subjects who appear to have hypertension according to the office measurements. White coat hypertension in diabetics. White coat hypertension is associated with a long-term greater progression of blood glucose abnormalities and increased risk of developing diabetes, and may present increased susceptibility to future weight gain and dyslipidemia. This is largely accounted for by the metabolic abnormalities that are frequent components of this condition. In a recent large study, white coat hypertension was present in 33% of the diabetic patients. These subjects may receive long-term unnecessary and expensive treatment. Thus, the only way to prevent overdiagnosis of hypertension is to confirm it by the 24 hours ABPM. Then coming to the identification of the masked hypertension. Masked hypertension is defined when office blood pressure is normal in an untreated subject and ABPM levels are elevated. This condition is present in 10 to 20% subjects who are considered to be normotensive according to the office BP measurement. Masked hypertension is more common in diabetic patients, and it may be present in 1 or 2 subjects with type 2 diabetes and apparently normal office BP. So several studies have shown that the cardiovascular risk in patients with masked hypertension is elevated and similar to the risk in patients with sustained hypertension. Then coming to the nocturnal BP, the physiologically BP falls by more than 10% during the night time, that is when we sleep. When BP falls by less than 10% during night time, it is defined as non-dipping, and nocturnal non-dipping is associated with increased risk of stroke, end organ damage and cardiovascular events including death. So the nocturnal hypertension night time BP more than 120/70 on ABPM. So normally BP decreases by 10 to 20% at the night, that is the normal dipping pattern. If it doesn't fall less than 0%, then it is considered reverse dipping. If it falls more than 0% but less than 10%, it is considered as non-dipping. If it is more than 10% but less than 20%, that is considered the normal dipping pattern, physiological dipping. If it falls more than 20%, then it is considered as extreme dipping. So the non-dipping and reverse dipping both increases the risk of organ damage and increases the severe events and mortality. This is, you can see the non-dipper, dipper and extreme dipper. Then coming to the blood pressure load, the BP load is defined as the percentage of ambulatory systolic and diastolic pressure exceeding 140 mm of Hg and 90 mm of Hg during the daytime and 120/80 during the sleep time. So, the overall BP load may also be detrimental for the cardiovascular events. Studies in untreated hypertensive subjects suggest that the likelihood of developing cardiac abnormalities is markedly increased when the daily BP load is more than 40% or more. So, ABPM guided management of hypertension, the progressive decrease in sleep BP in non-DP patient reduces cardiovascular morbidity and mortality, and therefore should be a therapeutic target. So, after starting medication, you can see whether dipping is occurring or not, and you can monitor the therapy according to the dipping. The bedtime treatment will be clearly indicated in patient with a non-dipping patterns, that is, you should give a tablet at the night when there is the patient is non-dipper. But if the patient is extreme dipper, then you should avoid the evening dose of the antihypertensive drug. ABPM may also identify patients with morning BP surge, that is, many patients usually develop a sudden increase in the blood pressure in the morning hour. So, it can be seen with the ABPM. Additional information which can be derived from ABPM can identify secondary hypertension, that is lack of nocturnal fall in BP may suggest that there is maybe associated sleep apnea. Performing ABPM is indicated in all patients with resistant hypertension to exclude white coat effect as a cause of the apparent resistance. It has been shown that 20 to 30% of patients with apparent resistant hypertension has normal BP levels according to 24 hours ABPM. Data derivative from 24 ABPM can be useful to diagnose the cause of syncope. We can find where this syncope is occurring because of the hypotension. It is useful to document fluctuating BP in patients with orthostatic hypertension, autonomic failure, or asymptomatic postprandial hypertension. The incidence of these pathologies is especially high in elderly patients, especially with the diabetes. Ambulatory blood pressure in addition gives information regarding the heart rate. So, you can see with the various heart rate variability with the blood pressure also. So, now coming to the ABPM in diabetic patient, ABPM is particularly important in the management of hypertension in diabetic patient, since hypertension is a major risk factor for cardiovascular disease in these patients. Diabetic patients are more likely to be non-dippers, and therefore office BP measurement may do not reflect the real cardiovascular risk. Masked hypertension is more frequent in diabetic patients, as I already said, and seems to be associated with increased organ damage. A wider use of ABPM in diabetic patient would identify more patients with masked hypertension, patients which are non-dippers, and which will help and improve the BP control. That is the reason ABPM is gold standard, and newer guidelines recommend. If you see the ACC/AHA guidelines 2070, prior to labeling a person with hypertension, it is important to use an average blood pressure average based on more than 2 readings obtained in more than 2 occasions to estimate the individual's level of blood pressure. Out of office and self monitoring of BP measurement are recommended to confirm the diagnosis of hypertension and for titration of BP lowering medication. In adults with an untreated systolic blood pressure more than 130 but less than 160, or diastolic blood pressure more than 80 but less than 100, it is reasonable to screen for the presence of white coat hypertension using either daytime ABPM or home blood pressure monitoring prior to the diagnosis of hypertension. Here again the ESC guidelines 2017 says that all patients with marked discordances between the office BP and home BP, association of for assessment of the dipping system, suspicion of nocturnal hypertension, for absence of dipping such as patient with sleep apnea or CKD or diabetes, assessment of BP variability, all this should undergo ABPM. Similarly, the CHEP 2015 out of office BP measurement should be performed, that is ABPM, to confirm the initial diagnosis any individual suspect of having hypertension. Again the USPTF suggests analytical framework, and they also shows that the use of require ABPM home blood pressure monitoring for protocols to in a patient with elevated blood pressure to confirm the diagnosis. So thus the ABPM becomes the most ideal practice because of the accuracy of readings. Better, it has got a better prognostic value, better control of the blood pressure, especially in resistant hypertension patients and day-to-day variability, white coat hypertensive effect, mask hypertension, and has a better long-term outcome. So ABPM is a reliable alternative to office blood pressure measurement, and it is, I think it is more it is use is increasing day by day. There was just one example. It is a patient with the white coat hypertension. You see the daytime blood pressure, there is a clinic reading is high. Then if you see the home readings, daytime blood pressure, nocturnal dipping, and early morning surge is there with the hypertension. You see the hypertension also, heart rate also. So ABPM various technologies, the mean 24-hour, mean active period, mean passive period, hyperbaric effect, dipping, etc. So early prediction of CV risk is possible with ABPM. It is better than home blood pressure monitoring, and it is much better than the clinical blood pressure monitoring. Thank you.